and you're good to go. Go ahead.
Great, thank you. So first of all, I want to thank the CCSN for giving me this opportunity to talk about cancer and heart disease and where the two intersect. Next slide, please. So over the next 35 to 40 minutes, I would like to discuss the impact of cancer treatments on the heart and the cardiovascular system, and what we can do as healthcare professionals to try and optimize cardiac health in cancer patients, not only during their treatment, but after they've completed their cancer therapy. And then what is the benefit of a multidisciplinary approach to optimizing cardiac health in cancer patients? Next slide, please. Cancer and heart disease really represent the number 1 and 2 causes of mortality in the Canadian population, as you can see in this pie chart here, designated by sort of the darker blue and the red pieces of the pie. And so really they're the top 2 things that we need to consider when we're treating the Canadian population. Next slide. Now we know that the predicted number of cancer cases is going to continue to grow over the next few decades, more so in the less developed countries, but also in more developed countries. So while we're making great strides in the treatment of cancer, there are still many people who are going to be diagnosed with this over the next few decades. And on the next slide, you'll see heart disease in the Canadian population still remains a large issue. Now, the good news is the number of Canadian adults diagnosed with heart disease is declining over the last several years, but still it's not an insignificant number of individuals who are being diagnosed or living with cardiac disease. As you can see, about 1 in 12 of Canadian adults over the age of 20 are currently living or have been diagnosed with heart disease. Next slide, please. The good news is that we know that there are a huge number of drugs that are currently in development for cancer. And in this slide, now a few years old, this represents the number of drugs that are being in various stages of development for cancer, all the way from phase 1, is when we look at cancer drugs first being tested in humans, through phase 2 and 3, where it's tested to see if it's effective, and then finally approved by the FDA and Health Canada as well. So if we look at other disease states, cancer by far has more drugs that are currently in development than just about any other disease state. Next slide, please. Also, the good news is that because of these drugs and earlier detection strategies, we are seeing more people surviving cancer. These are the estimated number of cancer survivors in the U.S. through to about 2025. And as you can see, this has significantly increased compared to the 1980s and 1990s. And so we are seeing effective management of cancer and people surviving from it. And next slide. And you'll see also in the Canadian population that looking at the top 3 cancers, lung cancer, breast cancer, and colorectal cancer, that the incidence rates has somewhat plateaued. But importantly, and if you click one more time, you'll see that significantly there, as of 2009, there were over 810,000 people who had been previously diagnosed with cancer 10 years before this, meaning that we're seeing an increasing number of cancer survivors in the Canadian population as well. Next slide. The issue is that in oncology, and when we're looking at trying to cure cancer, we have always focused on the cancer itself and not looked particularly at the consequences of our treatments. And so this is a quote by a cardiologist in the United States that said, while you are doing a great job at curing cancer, we are seeing these individuals who've been treated with cancer drugs months, years down the road with significant cardiac disease and sometimes heart failure. So the cured cancer patient of today does not want to become the heart failure patient of tomorrow. And so even if we are curing cancer, what are the consequences of doing that? And this is something that we need to look at. Next slide, please. There are a class of drugs out there called anthracyclines they've been around for decades that have been very effective in treatment of cancer. Some people call this drug the red devil because it does have an impact potentially on the heart. It also causes a lot of nausea and vomiting as well. But for today's purposes, I'm going to focus on what it can do to the heart. We know that this drug, when given in certain quantities, can decrease the strength of the muscle of the heart, and ultimately, this can lead to heart failure. And actually, you see death of the cardiac muscle cells. If you advance the slide one more time, you'll see that as we give increasing doses of this drug, particularly in people over the age of 65, there is an exponential increase in risk of developing heart failure. And on the next slide, you'll see they've actually done muscle biopsies of cardiac tissue showing destruction of cardiac muscle. So here's a perfect example of a drug that has made great advances in terms of curing cancer, but there are downsides to it. And so these are things we need to consider now as people are surviving longer and longer with their cancers and being cured of cancer. Next slide, please. But modern cancer therapy just doesn't affect the heart in terms of the heart muscle and heart failure. It has many side effects that can affect what I would call the cardiovascular system. One way it can do this is it can cause certain drugs can cause blood pressure to go up. So in patients who already have high blood pressure, they may develop quite high, even higher blood pressure with some of the cancer medications. It can make people more prone to having clots. It can cause potentially a heart attack, or at least ischemia that may look like a heart attack. So that's when not enough oxygen is getting to the heart, as well as arrhythmias, so unusual rhythm disturbances as well. So all of these things, depending on the particular class of cancer drug that's being prescribed, can happen with cancer therapies. Next slide. We also know when we look at cancer survivors, in particular the pediatric population, is that those who've received chemotherapy and particularly radiation, that once they get out 10 to 15 years from their diagnosis, there is a significant increase in the risk of a cardiac event. This is compared to their siblings who are otherwise healthy, the black line at the very bottom, who have a very low rate of cardiac events. So if someone had a cancer when they were age 10, if they had chemotherapy and then radiation, by the time they're age 30, they're already starting to see evidence of cardiac disease, where we wouldn't expect to see that in the normal population until these individuals are maybe in their 50s or 60s. We also know there's data looking at women with breast cancer, particularly left-sided breast cancer, who received radiation, and years down the road, they have developed problems with coronary artery disease. They can also get arrhythmias and pericardial disease. And so there's potential long-term damage down the road from the way we used to deliver radiation, particularly for left-sided breast cancer, as well as people who've had things like lymphoma or Hodgkin's disease where they had chest radiation. Next slide. And in fact, we have some newer data now just to show you the impact of this long term. So this was a study done in postmenopausal women. They were approximately 60 years, mid-60s and over, who had been treated for breast cancer. And you can see here the cause of mortality in these women. Once we got out to about 8 years after their diagnosis of cancer, cardiovascular disease became a higher risk of mortality from cardiovascular disease compared to breast cancer itself. Next slide. So what have we learned? I've just shown you some of the data and consequences of the therapies that we give in terms of cardiovascular health. What have we learned based on that knowledge? Next slide. Well, I think the significant things are to understand is that there are shared risk factors for both cancer and cardiac disease. So things such as aging, tobacco usage, diet, obesity, physical activity, environmental factors not only increase the risk of cancer, but they're also known risk factors for cardiac disease. And so when you put these all together in this diagram, you can see that potentially these can influence our risk of cancer but are also at the same time influencing our potential risk of cardiac disease. Next slide. Now, this is a rather complex figure, but it was put together by a colleague of mine, a cardiologist in Ottawa. But I think it really shows you that not only do we share common risk factors that can lead to cancer or cardiac disease, but there's an interaction between these risk factors. So if you look to the left of this slide, you'll see the shared risk factors such as smoking, obesity, and activity. That can increase your risk of cancer. Let's say you do develop a cancer, but if we look down on the left-hand side, it's increasing your risk of cardiac disease. And so what may happen is that you may develop a cancer, have surgery, be exposed to chemotherapy, but at the same time, you've got underlying subclinical cardiovascular disease that then may manifest itself once you are stressed by all these cancer treatments. So there really is a strong interaction between all of these, and that's really important to consider when we're thinking about what treatment to offer individuals with the new diagnosis of cancer, and also importantly, how we can try and deal with or even prevent some of the potential cardiac issues that patients may face. Next slide. It's also, as I alluded to, important to realize that frequently cardiac disease and cancer can coexist in the same patient. So if we look at the next slide, you'll see these are a number of studies that were done looking at large patient populations with prostate, breast, lymphoma, and colorectal cancer. And you can see that a number of these individuals already had, at the time they were diagnosed with their cancer, coronary artery disease, heart failure, hypertension, and diabetes. So this really shows you that what we're facing is not only do we have to look at an individual, their cancer diagnosis, and the best cancer treatments for them, but we need to consider this in the context of what they may have in terms of underlying cardiac disease. Next slide. Now, there have been great advances in cancer treatment, and I showed you just a diagram about the anthracyclines, which have been present since the 1970s. There was then a drug that came out called trastuzumab or Herceptin for women with breast cancer that was HER2 positive. But we are now moving towards what I would call targeted therapies. So we have these anti-VEGF treatments, which go after the blood vessels of cancer cells. So often cancer cells will promote the growth of their own blood vessels. So we try and cut that down to starve the tumor. You've got things such as checkpoint inhibitors, which really refers to immunotherapy. So many of you may have heard about diseases like melanoma, where we can give the immunotherapy to help the body boost the immune system to fight the cancer. And these have been very successful. However, on the next slide, you'll see this very complex iceberg diagram that shows you a whole host of new treatments that are coming down the pipeline that have potential cardiovascular issues, whether that be vasospasm, so you can get angina type symptoms, whether that be high blood pressure, you can get inflammation of the heart called myocarditis, and you can get arrhythmias. So what we have learned is that as these new drugs that are quite effective in treating the cancer are being introduced into clinical practice, we really need to pay attention to some of the cardiovascular issues that they can cause. Next slide. The question is, as this is happening, who is responsible for patient care? So next slide will show that if you're an oncologist, you might say, well, it's the cardiologist because the patient's developed heart disease. Or if you're a cardiologist, you may say the oncologist because the patient has cancer. And the next slide, you'll see really what we've done in the previous years is we've tended to work in silos. So I, as an oncologist, only worried about the cancer. The cardiologist would worry about the hypertension or high blood pressure or any heart disease. And we really didn't communicate between each other. And that really, I feel, has had a negative impact in terms of our ability to deliver treatment, the best treatment we can, safely. Next slide. So this really led to birth of what I call cardio-oncology. And the whole reason behind this was to try and provide the best cancer care while optimizing cardiac health. So what is cardio-oncology? Next slide, please. It really is a clinically based discipline that's focused on the cardiovascular health of cancer patients, not only during their treatment, but after they've completed their treatment, so-called cancer survivors, because you continue to be at risk, not only of the cancer returning after you've completed your treatment, but those individuals are also at risk of either developing heart disease, or if they haven't got that, if they've already got cardiovascular disease or heart disease, it may get worse the further they get out from their treatment. Next slide. And so, who is the cardio-oncologist? Well, it really is that healthcare professional who looks at what I call the 360-degree management of the patient. So they want to look after not only the risk of developing a heart issue while they're on treatment, making sure they get the best cancer treatment, and making sure after they've completed their treatment that they're on the appropriate follow-up so they don't get into trouble with either of these. So next slide. So how one could define this maybe as a healthcare provider that's focused on the prevention, early detection, management, and recovery of cardiovascular function, potentially resulting from cancer therapies. Next slide. Although cardio-oncology as a discipline is relatively new, it was actually a cardiologist from Italy who first presented a paper on this topic in an Italian journal in 1996. And so that was over 20 years ago. And really, it's only been in the last decade that this has been noticed and it's been become somewhat of a discipline in North America and around the world. Next slide. There are now cardio-oncology clinics that have been established, as you'll see on the next slide, with these little hearts all over North America, including many across Canada, over the last 10 years. There's also now clinics that have emerged in South America, in Europe, Eastern Europe, Western Europe, in countries such as China and Japan. And so you can see by all these little hearts that on this diagram that the number of clinics and programs has really exploded, I would say probably over the last 7 to 10 years. Next slide. So what does a clinic offer if you have a cardiac oncology clinic? Most importantly, it offers rapid access to cardiologists with an understanding of systemic and targeted therapies. So as I alluded to previously, there are a lot of new cancer therapies that are now coming into the clinic. If an individual who's going under treatment for cancer develops a problem and they're referred to a cardiologist who has no knowledge of this area, the problems are that they, first of all, may not be seen in a rapid fashion because the cardiologist doesn't appreciate the fact that we need to make decisions quickly, and that cardiologist may not truly understand what these drugs are and the importance of delivering them for cancer care. A clinic also offers opportunity for education, both of patients and healthcare providers. It offers opportunity for training of people that are just in their residency to try and make sure that they understand the complexities of treating people with cancer and potentially heart disease, and also the development of collaborative research, right from basic science research all the way through to clinical and health outcomes research. Next slide. Ultimately, the organization of a cardio-oncology program could look like this, and this is from just one journal a couple of years ago, looking at the cancer patient, and then as you can see there on the left-hand side of the diagram, you have a lot of healthcare providers involved in the team that look after the patient as a whole. You've got support from the hospital, social services, community, family and friends, education and research. It really is everyone working around the patient. And you'll see a lot of arrows going back and forth, which implies that we're actually communicating with each other rather than working, as I alluded to before, in silos and only taking care of that part of the puzzle or the piece of that care of that patient versus working as a team. Next slide. So recognizing the importance of this, in 2008, we established the Ottawa Cardiac Oncology Program. It was the first program and clinic actually in Canada. And subsequently, since then, of course, as I showed you with the many hearts across Canada and the US, there are cardio-oncology clinics in every major Canadian city. As you see here, it is a multidisciplinary team of consisting of medical oncologists, cardiologists. We had a research assistant, a pharmacist, as well as trainees involved in this program. Next slide. And recognition of this multidisciplinary approach, which was back in 2008, very novel. We received an Innovation Award from the Cancer Quality Council of Ontario in 2013. Next slide. The question is, does access to cardio-oncology clinics, though, impact patient care? And I think this is always a very important question. Next slide. So what we did is in our clinic, we actually collected information on all of the patients referred to our cardio-oncology clinic. And here is data looking at those numbers from 2008 to 2015. We saw close to 800 patients. And you can see that those patients were mainly breast cancer patients, GI, so colon cancer and rectal cancer, as well as GU, such as prostate, and then a smattering of other cancers. And the reason for referral varied depending on the cancer type, and often was related to the type of cancer that an individual was exposed to. So in breast cancer, for example, we give anthracyclines, and that can cause heart failure issues. So that's why many patients were referred for potential heart failure. Whereas in the other malignancies, it's more of some of the therapies, such as in GU, can lead to hypertension. So you'll see that sort of orange-yellow bar is a bigger piece of the pie. The good news is, if you look on the next slide, is that, and we focus generally on the breast cancer population, which are the two sets of bars on the left, those patients who had, and if you hit the next slide, I highlight this, those patients who had mild or moderate to severe left ventricular dysfunction, so the heart really was not working particularly well, the majority of those patients with either stopping the cancer therapy for a little bit of time and resuming it, or adding in cardiac medication, were able to complete their cancer therapy. So one of the things we felt was very important was, as an endpoint, at looking at the impact of these clinics on patient care, was completion of cancer therapy. And at least in this group of patients, and particularly in breast cancer patients, we were able to show that yes, with proper care, the majority of patients were able to complete their therapy. Next slide. And what we've also noted over the last several years, and this is an abstract that was presented at the Canadian Cardiovascular Conference 2 years ago, that patients now are being referred to cardiologists who have issues with regards to their heart function. So it's encouraging to see that patients are actually getting in to see cardiologists who have some expertise in this area. Next slide. So what's happened over the last several years in this new discipline of cardio-oncology? Next slide. Well, although we started our clinic in 2008, by 2011, we felt that it would be good to share what we had learned with our colleagues across Canada. So in 2011, I founded the Canadian Cardiac Oncology Network, known as CCON, and we actually invited a number of our colleagues to Ottawa to give them instruction on how to set up cardio-oncology clinics and cardio-oncology programs. We recognized that not everyone could travel, and so we developed this website at www.cardio-oncology.ca. And the main purpose of this website was to provide information and education for healthcare providers, but also there was a patient component to this website where patients could go in and they could read information about some of the therapies they might be receiving that could be potentially detrimental to their heart. They could read about potential heart tests that they might be exposed to or asked to do. And so it was really to try and enhance education across the country. Next slide. So for the first 4 years, we had meetings in Ottawa, national meetings, and then we felt that it would be a great idea to take this expertise globally. So working with our colleagues in the United States in 2015, we held our first global cardio-oncology summit, and there were approximately 240 healthcare providers, many from Canada, who met in Nashville, Tennessee, and really was the first opportunity that we had people from across the world coming together for 2 days to talk about how we could improve the care of cancer patients as well as maintain or even enhance their cardiovascular health. Next slide. So really developing cardio-oncology partnerships we felt was important in terms of how to move this field forward. And on the next slide, you'll see that over the last several years, there have been many organizations that have endorsed the development of cardio-oncology partnerships, including on the cardiology side, the American College of Cardiology, the European Society of Cardiology, ASCO, which is the American Society of Clinical Oncology, and ESMO, our European medical oncology partners, and the Canadian Cardiovascular Society. So we really felt that it was important to have these peer groups involved in promoting the partnerships. Next slide. And what has resulted from those collaborations is that over the last few years, a number of papers have been published from these different societies looking at how to best manage patients receiving cancer therapy, how to monitor them for cardiac dysfunction or cardiovascular issues, and even through into survivorship. How do we monitor people who have survived their cancer and we're now out several years? What can we do to try and prevent cardiovascular disease? So this is just an example of some of the major papers that have been published to provide some guidance. They're called position papers and guidelines. Having said that, the majority of this work represents expert opinion because as this is a new field, there isn't a huge amount of data out there that we would consider level 1 evidence. Next slide. There have also been a number of publications out there that are more patient-focused, and this is published by one of my colleagues, Javed Malehi from Vanderbilt. And as you can see here, this particular publication was looking at breast cancer survivors, and he came up with the ABCDE steps to prevent heart disease, as you can see there. So not only are we looking at how do we help cancer patients get through their treatment, but what are some of the tips to try and prevent problems down the road. Next slide. The awareness and of this area of cardio-oncology and the importance of it has grown exponentially, as can be seen here by the number of publications that have come out on the various topics related to cancer therapy and heart disease. So you can see back in 1996, there were 77 publications listed on PubMed, and now this data is only out to about 2014, really over 812. And I can guarantee you that probably out now to 2019, there would be probably over 1,000 publications per year. Next slide. In 2016, 17, we developed a cardio-oncology journal. So this was the very first time that cardiologists and oncologists have come together to work together to produce a journal specifically dealing with cardio-oncology and the topics that are coming up in terms of practical ways of how we can manage individuals with cancer. And on the next slide, you'll see this was just announced a few months ago that JACC, which is the Journal of the American College of Cardiology, will be publishing a cardio-oncology journal 4 times a year, starting in the fall of 2019. Next slide. The media has also picked up on the importance of this topic, and these are just but a few articles that have come out. So in this case, U.S. News, the connection between cancer treatment and cardiac problems. As more people survive cancer, doctors are discovering the long-term side effects of their treatment and minimizing heart damage after treatment. What are the steps both patients and primary care physicians should take to try and do this? So really emphasizing the message out for everyone that this is an important topic. And so I think this is really important because although cardiologists and oncologists are now agreeing to talk to each other and to try and solve some of these issues, we need to increase the public awareness of this. And certainly the media has been helpful in doing so. Next slide. So to summarize sort of the evolution of cardio-oncology, I showed you that in the sort of anthracyclines can cause problems, and that they date back from the 1960s and 1970s. And then in 1998, a drug came along called trastuzumab or Herceptin for breast cancer, and that caused some problems. But really, it's been the explosion of new targeted cancer drugs over the last 5 to 10 years that have led to the growing interest in this area and the growing number of publications and guidelines, as you see here. Next slide. So what are our challenges moving forward? Well, we need to have a better understanding of how modern cancer therapies impact cardiovascular health. We have good data on some of the older drugs, but as these newer drugs come into the clinic, how are they going to impact cardiovascular health? How can we identify those patients who are at risk of experiencing a cardiac event? Can we look at better ways to do cardiac imaging? There are certain blood tests called biomarkers that sometimes may help, but they're sometimes sensitive but not necessarily specific enough to help do what we want them to do. Can we prevent cardiac damage? So are there drugs that we can use to try and protect the cardiovascular system from the potential impact of the cancer drugs? Or if someone does develop cardiac issues, are there drugs that we can give them to prevent further damage? What are the best drugs to manage the cardiac damage should it occur? And importantly, what kind of surveillance or monitoring should we have in adult cancer survivors to try and make sure that if there is a problem, we pick it up early? In the pediatric population, they have followed pediatric cancer survivors for many years and determined a strategy around cardiac imaging, but we don't have similar data in the adult population. And then, of course, lifestyle modification. There's a growing amount of literature coming out on the benefit of exercise in terms of not only cancer, but cardiovascular health particularly. Next slide. Where there are challenges, there are always opportunities. So an active participation in growing cardio-oncology networks may provide critical clues on potential solutions for these challenges and open horizons for growth. So on the next slide, you'll see this collaboration. So this is a circle I created, and as you can see, it's under construction. And these are all the countries that have currently actively have cardio-oncology programs, and many of whom come to our annual Global Cardio-Oncology Summit. And you can see here, there's the Canadian Cardiac Oncology Network there highlighted, the British group. There's an International Cardio-Oncology Society as well, and the other societies are certainly growing and refining their programs. Next slide. While we have a good understanding of some of the issues, it's not always evidence-based, and not always do we have a true understanding of the best way to monitor patients and identify them, as I alluded to. So it's very important that we consider research moving forward. Right now, there are close to 200 clinical trials that are registered for the diagnosis and treatment of cancer-related cardiac dysfunction. You can look at those and find them by going to the clinicaltrials.gov website. I've put here just some examples. This certainly isn't all-inclusive, but as I alluded to before, further research needs to take place looking at how do we predict those who are going to develop cardiovascular problems? How do we monitor these people? Are there imaging strategies that we can use? Are there protection strategies we can use from cardiovascular compromise and cancer treatment? And we're also working to develop a registry of patients who are on these drugs so we can go try and learn from them as we go forward. Next slide. So I think the key messages really are that improvement in cancer therapies has resulted in long-term survivors who may be at risk of cardiovascular damage. We use the term cardiotoxicity, which is a fairly general and broad term. Individuals with heart disease may develop cancer and require potentially cardiotoxic cancer therapy. So as I showed you earlier in the talk, people may have both heart disease and cancer. And so how do we work together to try and treat the cancer without having a negative impact on the heart? Close collaboration among healthcare providers is needed in order to provide the best cancer care while optimizing cardiovascular health. And really, the establishment of cardio-oncology clinics and programs provides the framework for optimizing clinical care delivery, but also education and research and promotion of survivorship. Thank you. That ends my formal presentation, and I certainly would be happy to answer any questions.
Hi, Susan. Sorry, this is Allison. I have the questions here if you'd like me to read them out. I'm not sure if you can see them on your end.
Oh, maybe I can expand it. I don't see them right now.
Okay.
Let me see. Okay. So I see that there are some people who are on the line that are asking specifically about prostate cancer. That is certainly one of the areas that is being addressed in the realm of cardio-oncology. So one of the treatments for prostate cancer is androgen deprivation therapy, and we know that that can potentially cause cardiovascular issues. So while I don't treat prostate cancer myself, the Canadian Urological Association has been very active in this realm. I know I worked with them to try and develop some strategies for cardiologists and primary care providers to come up with ways to assess and ensure that prostate cancer patients weren't at increased risk, whether that be looking at, their cholesterol levels, blood pressure management. A lot of it makes common sense, but clearly there are that is an area of active research. So for this broad topic today, I didn't go in specifically into any one malignancy, but I'm certainly happy to provide more information and resources offline. Also, there's a question about, arrhythmias and atrial fibrillation. Certainly, we know that cancer patients are at already increased risk of atrial fibrillation, which is a type of arrhythmia. It's a heart rate that's irregular, and so patients do need to be monitored for this. And there's actually a lot of active research being conducted right now, looking at how to manage that. Of course, the fear is with atrial fibrillation is the higher risk of stroke from blood clots that form. And so for those individuals, a proactive approach needs to take place. We need to make sure that if these individuals do have atrial fibrillation, they need to be seen by their cardiologist or their primary care physician to ensure that they're on the proper medication to ultimately prevent a stroke. There is a question looking at doxorubicin, and do all patients who have received doxorubicin get cardiac complications? No, they do not. Doxorubicin is given in probably in the breast cancer, for breast cancer patients, we give less of that medication now than we used to. It is used in higher doses for patients with Hodgkin's and non-Hodgkin's lymphoma. When this drug is given, this class of drugs is given, it's very important that patients have baseline cardiac function testing done. It's usually with an echocardiogram or a MUGA scan. And if they're monitored throughout their treatment by having periodic echocardiograms, then it's important that the medication be either held or stopped depending on what their ejection fraction is. But suffice to say, not everyone automatically will have heart problems with doxorubicin, but as it's a risk, you just need to be monitored closely. And how it manifests usually is a drop in ejection fraction. If this happens, then you need to see your cardiologist. And if it's done in a quick fashion, usually there are not long-term consequences. What is harder to predict is those individuals who've had doxorubicin several years ago when we were giving it in higher doses. Some of those patients will remain at risk of developing heart complications down the road. And unfortunately, we don't have very good strategies to try and predict who will do that. I can also say that there are ongoing studies looking at giving medications up front to try and prevent damage from doxorubicin. So not everybody. The last comment I will make on that is that in some of the breast cancer studies where they use doxorubicin in combination with a drug called trastuzumab or Herceptin, the overall incidence was about 3 to 4% of heart failure. So I don't want people to go away from this presentation thinking that everyone's going to develop heart problems, but it is something that you need to be aware of and to be proactive about. Someone asked, are there any services in Atlantic Canada? There are not as many services as I would like to see. We have certainly some interest in Halifax, but what I would encourage, and I can certainly, you can go onto the website, that the CCON website, is that that website will actively try and match you with someone if you send in a question that would be interested in helping you. We are in central Canada, in Quebec, and in Western Canada, probably more services there. Halifax would be my best, but my recommendation would be to go onto the website and send a question, and we can certainly help you with that. How should patients or should the patient cardio-oncology clinic, or how does it get established? Really, it's through the interest of oncologists and cardiologists in the center in your city. I know that this is growing at exponential pace across the U.S. and in Canada. We, in fact, are having a Canadian Cardiac Oncology Network meeting in Montreal at the end of this month. That meeting is listed on the website, the CCON website. I would encourage those individuals on the line that if they're interested or if they know of any healthcare providers who might be interested, they have the opportunity, if you're in Eastern Canada, to attend that meeting. Also, though, to reach out to us on the website, and we certainly can try and help you. I've now been involved in many programs around North America and around the world, going to centers and talking to them about actually how to establish a cardio-oncology clinic. The most important thing, however, is to find two champions in your center, a cardiologist and an oncologist, who are willing to sit down and work together. Another question is, what percentage of those who've had doxorubicin treatment years ago for non-Hodgkin's lymphoma? I can't quite see the whole question. I believe it relates to the risk. The risk, I can tell you, is related directly to the lifetime amount of doxorubicin that an individual receives. So 450 milligrams per meter squared used to be the cutoff after which the risk would go up significantly. Having said that, it also depends on your age, other risk factors. And so if you had a large amount of doxorubicin years ago, then I think the recommendations, although there isn't a lot of evidence for this, would be periodically you're assessed for your heart function, because this can happen many years down the road after you've had your treatment.
Okay, I think that's all of our questions, Susan. So I think we'll